Professor in Department of Neurology in University Kansas Medical Center. She has many publications to her name, and I invite her to give her talks, and I hope we will get many of answer to many of her questions. Welcome, madam, please.
Hi, good morning, everybody. And thanks for giving me the opportunity to talk today. And about this, I'm sure all of you are experts in this field, and we all are learning along the way. There's a lot more to learn, as Dr. Viber mentioned earlier in this, but I'll be talking about some of the treatments that were already present, and then, go on with new treatments that are. So let me make sure I have the presentation up here. All right. I hope everyone is able to see the slides. Okay.
Yeah.
And these are some of my disclosures, as you can see below. And I'm consultant for some of the companies here. As we all know that myasthenia gravis is still considered as a rare condition because there are 25,000 cases in US and about 50 to 125 cases per million population. And it occurs in any time from childhood to adults. And usually there's two peaks. That is, you see like a peak at around the third decade and a peak around sixth decade. And usually females are more common than males in the younger age group, and whereas males, it is more common in males in the older age group. And we don't know why this is, but in general, most of the autoimmune conditions are more common in females in the younger age group, just like rheumatoid arthritis and other lupus and other autoimmune conditions. And just to go through the physiology of this, as you all know that what happens at the neuromuscular junction is the calcium enters into the the presynaptic membrane when the impulse comes to the presynaptic neuromuscular junction. And once the calcium enters, it attaches to the synaptic vesicles. The vesicles dock on the membrane and release acetylcholine. The acetylcholine attaches to the postsynaptic membrane, and there's changes in the ion channels. And you see there's a action potential that takes place in the postsynaptic. Why is it important to know all this? Why do we need to know the physiology? Again, the physiology is important because we are trying to target various areas of this to treat the patient. And once the acetylcholine is released into the synaptic cleft, it is breaking down by acetylcholinesterase into acetyl and choline, and so that's how we look at this neuromuscular junction. So these are various areas that you can target the medications, and so we want to keep that in mind. And I'm just going to go briefly with this, but in addition to that mechanism, there is another, like you need to remember that these vesicles also are functioning like through a series of proteins. The fusion, docking, and release of acetylcholine occurs. These are called the snare proteins, and they are synaptophysin, synapsin, there is synaptodrivin, and synaptogamin. These are some of the proteins that are useful to help with the fusion, docking, and release of the acetylcholine into the synaptic cleft. And why is this important? Again, the congenital myasthenic syndromes are related to this. That's the reason but I'll be focusing mainly on the autoimmune mechanisms of the autoimmune myasthenia gravis, and I won't be touching too much on the congenital myasthenia gravis because this 1 hour may not be enough to go through two of them. This is another whole different topic with congenital myasthenic syndromes, but the autoimmune myasthenic syndrome, again, this is the classification. We have autoimmune and congenital myasthenic syndrome. Among the autoimmune myasthenic syndrome, myasthenia gravis, we know the most common type that we all are aware of is the acetylcholine receptor antibodies, myasthenia gravis. In generalized myasthenia gravis, about 85 to 90% of the patients have acetylcholine antibody positive, and in ocular, only about 50% have these. Again, with cell-based assays, you might find a little higher levels there. I mean, the percentages might be more higher. And in about 40 to 50% of the patients who do not have the acetylcholine receptor antibodies have another antibody called MuSK antibody. And again, why is it important to know which antibodies they have is because the management slightly differs from acetylcholine to MuSK antibodies. And the other one which is coming up in recent years is the lipoprotein 4 low density lipoprotein 4 antibodies, which are also known as LRP4 antibodies. Again, these are 9 to 10% of the double seronegative patients have this as the antibodies. And in addition to this, there are other antibodies that are being being studied, which is agrin antibodies, the cortactin antibodies, the titin antibodies. These are again proteins that actually help with the post synaptic receptor. So they help with stabilizing the receptor there. So antibodies to these proteins actually cause the disease also. So there is a lot more to learn even in this area, because there are people who are seronegative. After you do all these, you find these seronegative patients, and you're convinced that these patients have myasthenia gravis. And I think it's because one of these antibodies, which we don't recognize yet, are positive in those patients and may need some more studies. And there are studies going on to recognize some of these, but the only three which are available for testing right now are the first three of them. That is the acetylcholine, musk, and lipoprotein LRP4. LRP4 is the latest one that is available commercially for testing. And then the congenital group is a heterogeneous group that do not affect respiratory muscles. And except for the familial infantile myasthenia gravis, you can see sometimes respiratory issues with these. And again, I'm not going to go into the details of this, but this is the congenital myasthenic syndromes can be heterogeneous, depends on where the defect is. And it could be either presynaptic defects or postsynaptic or synaptic defects. And, again, the symptoms might be different and the tests will be different for these. Again, like I said, this is a whole different topic that, needs probably another 1 hour to go over that. But, I won't be touching on that. And the treatments for those are different. The important thing to remember is in those patients, they never present with, myasthenic crisis. Usually they have more milder symptoms, and they do not present with respiratory symptoms, whereas the autoimmune type usually present with respiratory weakness. So just to go over the symptoms, I mean, what the classic presentation that you see in the clinic is that patient presents with double vision, ptosis, generalized weakness, leg weakness, fatigue, respiratory failure. As you can see, the respiratory failure is only about 1% of the patients. That's what I mean. That's how much we are talking about, like the initial presenting symptom. We're not talking about like any time during the myasthenia gravis, but we are talking about like when they present, usually majority of the patients present with double vision and ptosis, that is drooping eyelid. So unlike the acetylcholine receptor antibody positive patients, the musk myasthenia patients, that is the muscle specific tyrosine kinase MG patients, are usually younger women, predominantly facial, bulbar, and respiratory weakness is seen in these patients. So they usually have ocular bulbar symptoms, and relatively compared to the other MG, they have very mild limb weakness. And if you look at going on, I'm not going to go through the various tests, and again, that will be another topic if we go into the details of that. But we can discuss if someone has questions on that. How do you diagnose them? But I'll be focusing on mainly the treatments of myasthenia gravis, which is, I think, important for us when we are thinking about treatment in patients. So as you can see, the treatments have been started like way back in 1930s, when Mary Walker actually first started off, looking at neostigmine and physostigmine, and she has saying that these have helped a patient with ptosis, and she had reported this. And as we can see, there is a decrease in mortality over the years, and reduction in mortality, and this has been achieved due to the tracheostomy and the negative pressure ventilation and the physostigmine, neostigmine. So over the years, you can see the trending down of the graph where the mortality has decreased from 1930s, from 70% to 1970s, it's about 6%, according to Grob's muscle and nerve study in 2008. And now in the latest, it is less than like 1 to 3, I think 1 to 3% is what we know in 1990s. So you can really see the mortality has decreased. So we are doing something good, So although we say we don't know much about myasthenia gravis, we still see that the mortality has decreased. We did have some improvement in treatments, whereas if you look at the prevalence has gone up. Why is this? Because as we know more about the testing, the patients have been tested more awareness of the condition, and people are being identified more earlier on, and we are seeing improvement, and we are seeing that there is more testing and more people being identified earlier on. So the prevalence has increased, whereas the mortality has decreased. So there is more awareness presently. So looking at the disease course prior to and since introduction of effective treatments, there is marked reduction in mortality. The mortality is, as you can see, is in the dark lines here. The mortality is decreasing, whereas there's still a substantial cohort of unchanged disease. That is, the lines here, this is unchanged. As you can see, there is still patients that are, the disease status is stable, but it's unchanged. And as far as the remission, you can see the remission, this is from Grob's paper from 2008, and the remission is not, again, it's been stable, the same numbers, the numbers have not gone down. So you can see, although we have improved and reduce the mortality, improve the symptoms, but we still have a lot more to do to see if we can reduce this unchanged part, and also the therapies, and also the remission, can we improve the remission? That's what we are trying to see. And that's why we need more treatments to continue. So if you look at the treatments, over the decades, in 1930, when it was first, like physostigmine and neostigmine were identified for, as Mary Walker has shown that when she gave the physostigmine neostigmine to patients, it had a significant improvement in the ptosis. That was in 1930s, and since then, every decade we are seeing something new being developed. And so you see that in 1930s, thymectomy was first done, and then in mechanical ventilation in 1950s. And as we go along, you can see, I mean, the recent one is Eculizumab in 2017. We have FcRn receptors are being studied in 2018. So there is a lot more treatments that are being studied now compared to like what they were. But so there is many treatments that have been studying. So these are all the randomized control trials that have been done up till now. As you can see, there's a lot being done in this field. And so I just wanted to go over, I mean, in these trials, again, there are certain outcome measures that people use, and these are some of the outcome measures. I just wanted to highlight some of them. I'm not going to go through all of the outcome measures, but these are the important ones which are being used not just in research, but also in clinics, like, for example, right now we are doing tele. Can we have some outcome measure from the last visit to this visit, so that we can say that the patient improved or not improved based on the daily activities at home? But this is the quantitative MG scoring is something which the QMG is something the physician has to do. So this cannot be done at home, but this is something which a physician or a clinical evaluator does this. And basically what we're doing is what you would normally do as a neurologist in the clinic. You're basically looking at the grading each of the facial muscles, the limb muscles, and outstretched, so you're basically looking at the same thing that you would be doing in the clinic. So this has to be done in the clinic. So the higher the number, the worse, the more severe the disease. And this has been used as an outcome measure for many years. And the other one is the MG-ADL, which is the Myasthenia Gravis activities of daily living, which is, again, looking at, whether the patient is, this is something which the patient can fill out. So this is what we are doing actually in every visit to see if they have changed from the last. Usually, if there is a change of more than 2 points, then you know that if it is increasing by more than 2 points, they're worsening. If they're less than 2 points, if it's only 1 point, we basically say it's not a significant change. But this is something you can do over the phone also. Like, so this is, when they come to the clinic, you're basically doing some examination, but, that's your examination, your physical examination. But this may not always correlate with what they feel at home, what they are not able to do, what they are able to do. So we like to find out what they have at home. Like, are they able to do their daily activities? Are they able to lift their arms up? Are they able to brush their teeth? Do they need extra effort for this? This will all tell us that they're weak in the arms proximally or distally, based on their symptoms. So this is what it's going to capture. And this has been used as an outcome measure recently in a lot of studies. And so going on to the treatments, we all know pyridostigmine, or as its trade name in US is mestinon, but it's the first line treatment for myasthenia gravis for most of us. And I know some of us may start off with steroids based on the severity. Again, it can vary. But if someone comes in with intermittent, like they tell you I had intermittent blurred vision or intermittent slurred speech, then I would start them on pyridostigmine. And I mean, I had, for example, I had a, a professor in college. He came and he said, like, I have this intermittent slurred speech when I'm giving talks, and but he didn't have any other symptoms. So this might be a good medication to just start off on that. But there could be other, if they have more severe symptoms, you may start other medications along with pyridostigmine. But this is an acetylcholinesterase inhibitor, and we don't expect too much with this. Usually we start off with 60 milligrams, 3 to 4 times a day. But if they are at 4 times a day, for me, I feel like they need to be on another immunosuppressive medication. So I'll also like to touch on some things on COVID-19 intermittently while we are talking about each
List.
medication.
You will see everything together. You choose which one you want.
I'm sorry, I'm getting some sound. Like, do you guys want to mute if anyone is having their phone on? I don't know if they're asking a question or is it, I wasn't sure. But if you can mute your.
No, I think somebody's mic got switched on by mistake. Sorry.
Oh, okay. No, that's fine. I'm just making sure there's
Yeah.
no question in the middle. I'm fine with that. All right. So COVID-19, again, looking at each individual medication, I'm going to be touching on it. Also, with COVID-19, there's no scientific theory or evidence that this would worsen MG, and so no need to stop this medication, the pyridostigmine. And then going on to corticosteroids, the NFB inhibitors and inhibit cytokine production, and and decreases the inflammation. And these there have been some randomized controlled trials, but these were very small studies. Actually, there was only 13 patients in the study, but moderately severe myasthenia, like in this study, they used 100 milligrams or an alternate day equivalent, and they showed that 7 out of 13 patients improved with prednisone. And they had another study also, this Cochrane database review had shown 2 randomized controlled trials. The other one had 20 patients who showed improvement. Again, based on this Cochrane database review from 2005, they showed that corticosteroid treatment offers significant short-term benefit in myasthenia gravis compared to placebo. And they showed no difference in efficacy between corticosteroids, either azathioprine or IV immunoglobulin. And this is probably answers some of your questions, Dr. Vaibhav, earlier when we were discussing. But they have said that there's no difference between corticosteroids and either azathioprine or IVIG in this Cochrane database review. However, again, we'll discuss a little more, but in ocular MG, that was in generalized MG. In ocular MG, there's been one study that was started off by Michael Benatar and in Miami, and we were part of this trial. Actually, we enrolled like half of those patients, I think, in that study. The plan was to enroll 80 patients. However, they ended up having only 11 patients in the study. Again, it's difficult, as we all realize, to enroll patients in myasthenia gravis, so the minimal manifestation state was achieved in 5 out of 6 patients on the treatment phase, and whereas 0 in the placebo phase. And it took about 14 weeks for median time to attain minimal manifestation state. And the median dose was 50 milligrams per day, so anywhere from 15 to 25. And so they've seen that even though it was a small number of patients that completed the study, there's some benefit in using this in in ocular myasthenia gravis. Again, like I mentioned, it's very difficult to do MG studies, and ocular MG is even more difficult to do because, again, the number of patients is less, and again, it's hard to enroll patients in any treatment trials. And so treatment statements, again, as we were discussing earlier, Dr. Vaibhav, I think we were touching a little bit of this different people, like individual physicians have different ways of doing it. There's actually 3 approaches that people use for corticosteroids. One is the high dose approach, where they start off with the high dose and gradually taper it down. And then there is a low dose approach that they start off at 10 milligrams and then gradually increase it by 5 milligram or 10 milligrams every few days and go up. And then there is a in between where people just use like a steady dose, like 20 milligrams. That was used in actually the SUSEP trial. They just put everyone on just 20 milligrams of prednisone, and that is the in-between trial. So is there a good answer to which one should we start? I don't think there's a good way, and it depends on how severe the patient has symptoms. And you also have to remember that when a patient comes in acute worsening of symptoms, if you start the high dose steroids, you might actually worsen the symptoms. And why does this happen? We don't have a better idea of that, but it happens. So usually when they are in exacerbation or getting close to crisis, we just don't increase the dose suddenly, but we try to admit them to the hospital. And once they're in the hospital environment, it's okay to increase it, because if they need intubation, at least they are in the hospital. So that's something which we use. And when you're tapering it down, we try to taper it down either 10 milligrams per day dose, like once monthly, or 5 milligram per day. So this is the commonly used method of tapering down. And then going on to azathioprine. Again, I'm not going through the side effects of that, but there are a lot of side effects with corticosteroids, and that is one of the reasons why many people prefer starting another medication along with that. Some patients do not like it because of, again, there is bone density loss, there is calcium. They have to be on calcium and vitamin D. We start them on, and bone density you have to get at baseline and at follow-up, and they may have like swelling in the legs, they may have high blood pressure, high blood sugars. These are all some of the side effects that you would experience with this. And mood changes, that's another common one, which especially young people might mention that. And then the weight gain is one of the major one that they don't like if it's a young female patients. So the other treatment that we commonly use is azathioprine. Again, there have been case reports in late 1960s and case series through 1970s and 1980s. And there has been one randomized non-blind trial of MG in France that showed that prednisone versus azathioprine showed that there are fewer people that deteriorated and had failures in azathioprine group, whereas monotherapy failures, they did better when they were on both treatments, that is the azathioprine and the prednisone together. But the main paper that we all talk about is the Palace was by Palace in neurology in 1998, where they had 34 patients on the treatment, and this was either they were on prednisone alone or prednisone with azathioprine. As you can see, most of the studies we use prednisone along with another medication or prednisone alone, because prednisone has become a standard of care for most of the patients, and most of the physicians use this as a standard of care. So it's hard to do trials without with just placebo and not putting them on prednisone. So this was one of the earlier trials that looked at a primary endpoint was prednisone dose measured at 12 months and at 36 months. And what they have noticed is up to 12 months, there wasn't much of a difference between the two groups. So if you look at this, this was a median prednisone dose. So the outcome they were looking at is the prednisone dose, and they under the curve, and basically they're seeing that the dose was not much different at between the placebo. This is the placebo group, and this is the I would say prednisone alone group, and the prednisone and azathioprine group, the prednisone and placebo group, and the prednisone and azathioprine group. And you can see at 12 months, there's not much of a difference, but as they beyond 12 months, they start separating out. So there was no difference until 12 months, but after 12 months, you start noticing some separation, and most separation is like 15 months, and a marked difference was seen by 36 months. So this is something to remember. So that's why we say that it might take a long time for this to take effect. So that is one of the reasons why we say we start on prednisone and rather than starting on some of these other medications, is because they take a longer time to kick in, whereas the prednisone is much faster. And the other important medication that we all know is mycophenolate mofetil, or it's also called Celsart in US. Again, this 2 randomized controlled trials were conducted. So this is an inhibitor of adenosine monophosphate, and basically depletes guanine and inhibits with the nucleotides and T and B cells. And basically these 2 studies that Don Sanders has performed, one was FDA approved, basically funded by FDA. And the patients enrolled in this were 80 subjects. They were all acetylcholine antibody positive patients and no prior immunosuppressive therapies. And they were placed on 2.5 grams of mycophenolate mofetil. And all of them were on prednisone 20 milligrams. So these were all patients on 20 milligrams. And the primary outcome in these patients was QMG that I talked to earlier. And what they saw was at 3 months, they did not show a significant difference between placebo and mycophenolate mofetil in the change in QMG, or mean total QMG did not change. And the Aspreva study, which included 138 subjects. So these are huge studies. These are not like few patients. These are a huge number of patients, and so they can, in this study, they can already be on prednisone, and it was a 9-month trial. And so both of these studies were negative, so they did not show significant difference with placebo. So why do we think these trials are negative? We don't know actually, but we think that there are a few things that might have caused us to be negative. One is the drugs do not work. Probably we don't know that. And prednisone improved all patients because all these patients were on prednisone. Maybe it's the prednisone effect that is masking the effect of mycophenolate mofetil. And the studies may not be long enough, or the endpoints may not be good. Maybe it's MG-ADL we should take and not QMG. We don't know that. And non-homogeneous populations were enrolled. Maybe we have like milder cases in this, or maybe we need like more severe cases, or maybe it works in only certain types of populations. So these are all the questions that we don't know the answers to. But some people still use this as a treatment, as in their clinics, and I still use it like as a probably lower down. I mean, it used to be my first line when the trial was going on because it has less side effects. It can cause leukopenia, but it is a good medication, not severe side effects like some of the other medications. So I still use it, but like it's lower on my list right now. And but with two trials being negative, many people do not use it. If you ask the evidence-based doctors, they say that you shouldn't be using that. But the phase 2 trial of methotrexate in MG, this is another trial that we have done. We were the primary site at KU. This was FDA funded trial, which again, as you know, methotrexate inhibits dihydrofolate lactase, an enzyme that participates in the tetrahydrofolate synthesis. And so with this study included 50 subjects, so we included 50 subjects. 25 of them received methotrexate, which is 20 milligram orally weekly, and 25 received placebo. They were on placebo, and this was a 12-month study. And I'm sorry. And the hypothesis is like adding methotrexate would decrease the prednisone dose. Again, all of these patients were on prednisone, and the primary, and they were tapered down, and they still had symptoms. So those are the patients we enrolled into the study. And the primary measure of efficacy was 9-month prednisone area under the curve. That is, we wanted to see if patients on methotrexate had lower prednisone requirement than patient on placebo. And secondary outcomes for QMG, MG-ADL, MG composite, MG-QL. So there were 20 sites. We had to have 20 sites with the Canadian site also enrolling into this study. And because like I mentioned earlier, it's hard to enroll patients into these studies. And the conclusions were basically the conclusions were negative. We did not achieve the primary endpoint. However, there were some trends in the secondary endpoints, and we still think that this might work. However, like I said, although the study was negative, we are considering a new trial using a higher dose, maybe 30 milligrams actually, and using the subcutaneous route rather than an oral route. So this is something which we are working on, and hopefully we can bring that up. And this was published in Neurology in 2016. And so we finished talking about like some of the immunosuppressive medications. So what are the effects on COVID-19? Again, that's always on our mind with the present situation. So there is strong evidence is lacking for worsening of increased risk, but we all know that again with immunosuppression there's going to be some increased risk in these patients. But would you stop this medication? Probably not, because if you make changes to the medication at this point for someone who's very stable on MG and on these medications, you might actually worsen the MG, and they may end up in the hospital and get more exposure to infections. So we recommend having extra precautions, avoiding people who have infections, and trying to be better with the hand washing and those kind of taking preventive measures. And sometimes they may have to increase the steroids in some situations, but usually, like I mentioned, you don't want to stop their medications in this acute situation. So going on to IVIG, again, a lot of us use we use a IVIG frequently on Myasthenia Gravis patients. So what do we have evidence on this? The Dr. Vito Brill from Canada has done a study which actually used, they have done they enrolled 51 patients into IVIG group, and 51 patients with either IVIG or placebo group, 1:1, and with significant difference. They showed the QMG showed significant difference at day 14. So that's why we say it takes about 2 weeks for the full benefit of this medication, the IVIG treatment, and it persisted at day 28. And the QMG scores for IVIG there was a change of 2.5 points, and whereas placebo was 0.89. So there was a significant difference between the two groups. And the post-intervention status at day 14, the IVIG improved in 25% of patients, whereas placebo improved 6%. So there was a significant difference again. The repetitive nerve stimulation zinc fiber EMG did not change much, but between the two groups, we did not see a significant difference. So how do we dose this? I mean, I think most of us know the induction dose is 2 gram per kilogram, either 0.4 gram per kilogram, 5 days, or some people use it over 3 days, or you can even do over 2 days. Again, you have to be careful. In elderly people, it's better to go slower, whereas in younger people, because it can cause congestive heart failure if you give a large amount of fluids at once. So you want to make sure that, based on the age and, the other medical conditions, you use any of these dosing. It's basically you have to give 2 gram per kilogram over 3 to 5 days is what we normally use. And maintenance dose for chronic disease, is there evidence of this? There have been some retrospective studies, but prospectively there was the Griffiths had done a study, and it hasn't been published. However, we use approximately 0.4 to 1 gram per kilogram every 3 to 4 weeks. But some people may need infusion anywhere every 2 to 8 weeks. Again, this varies with the individual person, again, and their symptoms. So we change it based on the symptoms. So plasmapheresis. Coming on to plasmapheresis, it directly removes humoral factors such as autoantibodies, immune complexes, complement, and other non-specific inflammatory mediators. And it removes about 3 to 6 liters of plasma over several days and replaces with albumin, or you can replace it with purified protein fraction. And it's usually used for crisis, or when patients are going for thymectomy, prior to thymectomy, to make them stronger, or if they have severe myasthenia but not in crisis, you can still use this. And chronic, or for some people use it for chronic treatment. Again, the IV access is a problem. When they're in the hospital, like in crisis or before thymectomy or with severe MG, it's you can just put a temporary double lumen catheter. But if they need chronic treatments, again, leaving them with a double lumen catheter, there's a risk of infection. So, I mean, there are a few ports that you can use, but again, it is difficult for the patient to maintain that, port, and it is a surgical procedure that they have to use. We had used fistulas in the past, but again, these are monthly, unlike dialysis, they do every few days, so they get clotted off, and that's again can be disfiguring for some of the younger patients. So this hasn't been used as much for maintenance, but we use it more for acute exacerbations. And comparing IVIG to plasma exchange in myasthenia gravis, this was a study by Bath. They looked at 84 patients, either to IVIG 1 gram per kilogram per day, or for 2 days, or plasma exchange for 5 days. And the QMG of these patients was greater than 10.5, or worsening, so moderate, and then moderate to severe. And what the study showed was about 69% on IVIG improved and 65% on plasma exchange improved. So the conclusions were that IVIG and plasma exchange are equally effective. So you can choose either of these when the patient is in crisis. The only problem is, why we prefer plasma exchange over IVIG is if they come into the hospital and are intubated, and you're giving them IVIG, and then you find out that the patient is not improving, or you have to wait for 2 weeks to see if they have full improvement. And then some people think, should we do the plasma exchange right away? So that becomes a dilemma. You just gave IVIG and you're cleaning it off with plasma exchange. So instead of this, it would be better to just do the plasma exchange if they're in crisis. That would be faster recovery. Usually we see the improvement by the third treatment, plasma exchange, whereas IVIG, it may take a little longer. So we prefer, if they're in crisis, to do plasma exchange followed by IVIG. But again, some people do use IVIG in place of plasma exchange. And so in relation to COVID-19, is there evidence for plasma exchange or IVIG to worsen the risk of infection with COVID-19? So there's no evidence to suggest that these carry additional risk in in these patients. But extra precautions like, when you're giving maintenance IVIG, the patients either go to a infusion center or some people get it at home. It's better to get it at home so that we can reduce the risk of infection. But if they go to outpatient center, the risk might be more because they're exposed to other people with IVIG. Again, plasma exchange is the same thing. They have to be admitted to the hospital, and there might be more other patients that they are exposed to with the COVID-19. So it's better not to do these, if we can avoid it, and if they can get it at home, the IVIG, that would be better. So going on to rituximab. So how does it work? It binds to CD20 epitopes of the B cells, leading to depletion of circulating B cells, as well as interfering with B cell proliferation and activation. And there was a study, BEAT MG, rituximab in MG study. This is with generalized MG. This is by Dr. Novak and his group, and there were many other centers that were involved in the study. It is a phase 2 trial with 52 subjects, and the primary endpoint was looking at the steroid sparing effect. And the final results were like this: did not achieve primary endpoint, which were shown at the AN. The results were, these were presented at AN last year. However, this is not yet published. They're still looking at other analysis on this, and so we would not know the final results until that is published. But the other thing we have to remember is like rituximab. We're talking about generalized MG with acetylcholine receptor antibodies. But there has been some other studies that showed that it may be useful in Myasthenia Gravis patients. So that is it's still a choice of treatment for patients with Myasthenia Gravis. And then there is a phase 3 study ongoing in Sweden that's with new onset generalized MG. The results will be presented sometime later this year. And going on to subQ MG, what is the data in that? So again, this might be an option in COVID-19 era because, this is something which the patient can do it by themselves rather than coming to an infusion center and being exposed to an outside. But this is a study funded by CSL Behring and by Dr. Dimashki at KU is a PI on this, and we are also investigators of that. It is a phase 2 multi-center trial with the primary outcome is looking at endpoint at the QMG less than 3 points, like change over QMG of less than 3 points from week 0 to week 12 for patients who are on IVIG. We're transitioning them to SubQIG. So these are patients who are stable on IVIG. We are transitioning them to SubQIG, and the results have been positive in this. So MG patients can be transitioned from IVIG to SCIG, and the conversion that has been used in this is 1:1.2. And however, you have to remember in the Isentra trial with CIDP, they used either a 0.2 gram per kilogram or weekly, or they have used 0.4 gram per kilogram. They didn't have like a exact conversion in that trial. And they have shown that 0.4 might be slightly better than 0.3 gram per kilogram weekly. This publication is still pending right now. And let's go on to thymectomy. So what is the evidence supporting thymectomy? The first reported case was in 1912, which showed some improvement after thymus gland was removed. And total thymectomy was first attempted by Blaylock in 1941. And the latest trial, which we all know of, was published in the New England Journal of Medicine, and Dr. Gil Wolf. And I'm sure a lot of you were involved in the study, and it's by Dr. John Newsom Davis, who was the primary principal investigator of that. And what they've done is like they randomized people into thymectomy group but all the patients were on the prednisone. They had two groups, the thymectomy versus non-thymectomy group, and primary endpoint was the QMG score, and they showed this is the quantitative myasthenia gravis total mean total score, and they have shown this is the placebo, this is the thymectomy group, and they've shown the difference in the thymectomy group versus, and this was at 6 months. You can see there is a difference significantly lower in thymectomy group versus the placebo group. And when they did the sub-analysis, they showed it was the women, there was more benefit in the women, and lower though not significant in men, and was significantly lower in less than 40 age group than over 40. And in the the endpoint, the other endpoint they looked at was time-weighted average prednisone dose. Again, it was, you can see placebo versus thymectomy group. There was a significantly lower prednisone in the thymectomy group versus not the placebo group. So again, the subgroup analysis showed the similar findings like the other one, lower in women and men, and significantly lower in less than 40 and greater than 40 age group. Additional benefits, what they have noticed with the thymectomy is that there are fewer hospitalizations in the thymectomy group compared to the non-thymectomy group, and lesser need for starting azathioprine. That is, some people still needed to be on immunosuppressive therapy in some of these patients, but however, there were lesser need in the thymectomy group. And they also looked at 2-year extension of the methotrexate trial, which was published by later on by Wolf and in Lancet Neurology. Again, they looked at 2-year extension, and the benefit continued over the 2 years period. And so finally, so what can we say from all these trials? That so if the patient has a thymoma, we all know that it has to be resected. So there's no doubt about that. For the treatment based on histological classification, that is, based on the grade of the tumor, you decide whether they need for the chemotherapy or radiation, and based on whether they're elderly or multiple morbid, you look at palliative or radiation therapy. If they don't have thymoma, that is when the question comes: what do they need a thymectomy or no thymectomy? So these are the patients. I mean, right now we have a positive study, so we recommend thymectomy for all the patients who come in with acetylcholine receptor positive antibody, myasthenia gravis, and however, if they have MuSK or LRP4, or if they have triple negative, we don't recommend that. And if they are very young or if they are over 65, we don't recommend that because the study did not include these patients. So we don't know the benefit in that. But otherwise, we enroll all these other patients. And the other thing is the failure, intolerance of immunosuppression. They still, some people may still need immunosuppression, and then again, they go into remission. It's hard to say. This was improvement in the QMG. We don't know the exact how many people will go into remission with this. The thymectomy, the procedures, various procedures have been tried. The procedure that has been in the study was open thymectomy. Whereas, so the various procedures of the sternal splitting, that was in early 1900s, the maximally invasive, that is 1980s, transcervical approach has been tried in 1988. And now presently what we use mostly are the VATS procedure, video assisted thoracic surgery, or the robotic, that is the Da Vinci, which are less invasive. And most of the patients like these. However, you must remember that these are not the procedures that have been done in the study. So although that was an open procedure that was done in the study, the most commonly used ones are the VATS and robotics, which most patients like. But again, this depends on the size of the tumor also. If they have a larger tumor, they may have to have an open study. That, again, the surgeon decides what they have to be, which procedure needs to be done. And so going on to the role of complement, this is a new area that has been recently studied significantly. So what happens when the antibodies attach to the receptors? There is activation of the complement cascade, which leads to formation of the membrane attack complex. This membrane attack complex destroys the morphology of the muscle membrane. So when there's destruction of the muscle membrane, that's the mechanism of the complement, and what the Eculizumab does is it inhibits that C5 complement. It's a C5 complement inhibitor. So this is a new area that has been greatly looked at in the recent years, is the complement inhibition. Does this cause, help in myasthenia gravis improvement? So the REGAIN study was a large study that was done with 125 patients, either on Eculizumab or placebo, And it was a 26-week study with the primary outcome being MG. Actually, the primary outcome was the worst rank analysis on MG-ADL, but so that the FDA had required them to use the worst rank analysis, which although the primary outcome was not met in the study, all the secondary outcomes, including the MG-ADL, showed that this is the Eculizumab, this is the placebo group. You can see there's a change in the from baseline of the mean total scores in this one, MG-ADL, and then we have the QMG, the MGC, which is the MG composite. The MG composite is a combination of QMG and it was developed using the QMG and the MG-ADL. Combining those two, this was developed. And then there is the MG quality of life. So all the secondary outcomes showed benefit. You can see the difference between the placebo and the treatment group. So all of these showed there's a significant difference between the two groups, although the primary outcome was not met because it was used the worst rank analysis on this. But however, based on this, and also looking at the long-term safety and efficacy of the Eculizumab, as you can see, what they did was all the patients were enrolled into the extension phase where everyone got the medication. As you can see now, the placebo and the treatment group basically have the same outcomes there. That is because all the patients now got a medication, so everyone is in the treatment in this group. So you can see the outcomes are same as the treatment. They all improved after. They all had a significant change from the baseline after in the extension phase. So we think that this, again, 56% of the patients achieved minimal manifestations and were in pharmacologic remission. And so this showed that there is improvement, and this was the basis of the approval. The REGAIN study was the basis of approval of the medication Soliris, which you all know, or Eculizumab, which has been indicated for treatment of adult patients with generalized Myasthenia Gravis. Although the study was done on refractory patients, that is patients who who tried a lot of medications, this has been when they gave the approval, the FDA did not put that in the list. They did not say that this has to be given only for refractory patients. However, it is still used for patients who are refractory to other medications. And the doses are you start off with 900 milligrams weekly for 4 weeks, and then you put them on 1200 milligrams for the 5th dose. And after that, every 2 weeks, you give 1200 milligrams IV infusion. So again, but however, you have to remember there was a increase in the meningitis in this. With this, that's why all the patients do require meningococcal vaccination prior to starting their therapy. So that is important to remember, because the C5 inhibition causes increased infection with meningococcal infections, basically encapsulated infections is increased. Risk is increased. So that is every 2 weeks. So it is a bit cumbersome for patients to come in every 2 weeks to get the infusions. So the Alexion is looking at other treatment trials, which is Revolizumab, which is it has an increased half-life. That is, instead of every 2 weeks, this can be given every 8 weeks, which is this is a study which is ongoing. It's a phase 3 trial, and treatment period is 26 weeks. Open label for extension is for 2 years, and total of 120 to 140 sites will be participating in this trial, and total number of patients, again, is a large number. The criteria to enroll is MG-ADL should be greater than 6. Again, every trial has a certain MG-ADL that we look at, and the primary endpoint is change in MG-ADL at 26 weeks. And this study is expected to be completed in 2021. And then the other study that has just been, and the phase 2 has been completed, but phase 3 is ongoing, is the Zilco plan, which is it's actually a raw pharma study, which looking at subcutaneous injection. That is, you can the patients can give it by themselves instead of an IV infusion like the other two. This is also a complement inhibitor. However, this is subcutaneous injection. And like I mentioned, the phase 2 trial is already been published, and the recruitment is completed. Results are published in 2020. And this showed that of the 44 patients that were enrolled, improvement in QMG at 12 weeks was seen, and 0.3 gram per kilogram was used daily. And an extension study is still ongoing for this, and a phase 3 trial is ongoing for this. So this is another medication, is an option for patients instead of doing, but that has to be daily. So again, it might be a little cumbersome. If you can get the every 8 weeks, that would be good. The role of So going on to the other interesting new therapy that has been being developed is the FC receptor blockers. These are neonatal FC receptor blockers. So what happens is the IgG subtype antibody in the acidic environment, it basically binds to the FC receptors in the and prevents it from being lysed in the by the lysosomes, and this is how they are released again into the bloodstream. So if that can be blocked, blocking of that FC receptors, these will be exposed to the unbound proteins will be degraded in the lysosome, and that in that way you're basically taking or removing all the acetylcholine receptor antibodies or myasthenia gravis causing antibodies, which are of the IgG subtype. So that is the mechanism that we are looking at in these with these medications. And there has been a phase 2 trial by with this medication by Argenx, which was efgartigimod. Again, I can pronounce this, but efgartigimod is what it's called, and it's an antibody fragment FC receptor blocker, and it has been shown 24 patients were enrolled in multiple sites, and they have shown improvement in QMG as well as MG-ADL, and MG quality of life and MGC have been improved. And this is a IV administration, and it's done weekly, and it has to be done in a few 5 treatments, and then you wait according to the trial. But the phase 3 trial is ongoing. Actually, the enrollment is completed. However, the results are still pending on that. So we need to see. There has been a flurry of these trials that came up with the FC receptor inhibitors. And there is the Mamatha, another pharmaceutical company, is doing a phase 2 trial with 60 patients. And the subcutaneous form also being tried by UCB Pharma, and Immunoglobulin, another, is also trying this new treatment. And the important thing to remember is, like, again, they have the company has mentioned that this does not worsen COVID-19 risk. So these are some of the treatments that maybe even the I forgot to mention, even the complement inhibitors do not cause an increased risk of COVID-19 infection. So these are okay to use because, again, the mechanism is lower beyond it causes the complement inhibition, which is not the mechanism that the infection is caused with it. And then going on to the other treatment trial that's ongoing. Again, most of the trials that I've been talking about are acetylcholine receptor antibodies. Again, there are other antibodies that I mentioned earlier on, the MuSK, Myasthenia Gravis. Some of these trials also include MuSK patients. However, they're not specifically looking at MuSK patients, but this trial by Catalyst Pharmaceuticals has been, and this is looking specifically at medication which we all know as Thifodap or amphiperidine phosphate. And it is enrolling 60 MuSK patients. And this is a medication that has been approved already in Lambert-Eaton myasthenic syndrome. And it's a non-specific voltage-dependent potassium channel blocker. So by blocking this, it causes depolarization of the presynaptic membrane. It slows down or inhibits the repolarization. So prolonged depolarization results in opening of slow voltage-dependent calcium channels, so that allows more influx of calcium and causes increased concentration of intercellular calcium leading to release of synaptic vesicles, causing increased acetylcholine release into the synaptic cleft, and that leads to more acetylcholine being available at the postsynaptic membrane. And this has been, like as mentioned, approved for LEMS already, but the common side effects with this are perioral and very peripheral paresthesias and gastrointestinal disorders, and other side effects include rare seizures and cardiac arrhythmias. So these are all the, just summarizing it. And again, when we think of a medication, we're thinking of the annual cost of the medication. You can see the stable. I mean, prednisone is probably the cheapest of all these medications. And if you look at Soliris, which is the recent one, it costs about 500,000 annually. For the treatment. So it is an expensive treatment. So again, this also comes into your play when you're thinking of what medication to start on the patients. So these are our recommendations presently. In 2007, these were our recommendations. Again, these are our recommendations at KU, but I wouldn't say this is the recommendations by everyone. Again, it varies with individual, physicians, but we mentioned these based on the various randomized control trials and that have been positive. Again, I did not touch much on the cyclosporin, tacrolimus, or cyclophosphamide. Again, I think those are some of the other trials which showed, cyclosporin showed a positive trial and tacrolimus had a positive trial. That's why we have it as second line. But you can see the first line is pyridostigmine, prednisone, thymectomy. The second line is azathioprine, cyclosporin, IVIG. These are our present recommendations. And plasmapheresis, eculizumab, and then fourth line is rituximab, mycophenolate. So we brought down the mycophenolate mofetil because of the negative trials and methotrexate. So I think that's all I have. And any questions? I know I went a little fast in some of the areas, but again, in the interest of time, I just was trying to cover everything. Thank you all for this opportunity, and I'd be ready to take any questions.
Okay, let me Dr. Vaibhav and Dr. Duberkar will be joining us again. But it was an excellent talk. I want, Danny, you want to take the questions?
Yes, sir. There are many questions.
Yeah.
Yes, I'll just.
Dr. Dhananjay, can I take the first 5 questions and then you can take rest? You said you
Yes,
will
sir.
prepare
Yes, sir.
the point.
Yes, sir. Yes, sir. You take first five questions. I have PowerPoint.
Yeah.
I will upload me.
Thank you, madam, for such a exhaustive talk and such a wide coverage. Thank you, sir, for keeping this topic in this. There were 260 participants even this morning. 270 participants I could see. I think there are more. So there was a huge crowd and there was very nice questions, and which covered, which are having many varied areas of the myasthenia gravis. Although madam gave an exhaustive and covered almost everything. I will just ask the 5 questions as Dr. Dhananjay told me. Later on, he will make a PowerPoint and tell. So I have just picked on one particular aspect of the myasthenia gravis, which is thymectomy management, perithymectomy management. And I have summarized the questions in that respect. So ma'am, here are the questions asked, and one or two are mine. So first question regarding the pyridostigmine management is, what about the patients who have come to you after more than 1 year of the course of illness, or after and are actually more than 65 years of age but are perfectly healthy otherwise? Will you prescribe the thymectomy in these patients or not? More than 1 year?
Yeah, more than 1 year. Again, so first thing is, if they're above 65, we don't have any data on saying whether it'll help or not. As we all know, the thymus gland regresses as we age. And so we don't know we don't have enough evidence to say after 65, would that help or not? That's the first thing. And if they are 1 year, I think up to 3 years, I'm okay with doing the thymectomy on these patients. if they are, say, again, you want to stabilize them before you send them to, to to thymectomy, for thymectomy. So that would be
Second
my
question is, yeah, second question on the same aspect is, can the patient be on steroid and other immunotherapy, immune suppressive agents before going to the thymectomy? If so, what are the doses? Especially, what is the safe dose of steroid before surgery? And can we give the other if the patient is already on azathioprine and other drugs? What should we stop them on? How we should manage this case before
So
thymectomy?
we haven't stopped any patients on immunosuppressive medications when they go into thymectomy. As far as the dose of prednisone, again, it varies with the surgeon's level of comfort. Sometimes, I mean, usually they like it to be less than 10 milligrams is what I've seen mostly. Most of the surgeons ask me to like get them to 10 or below 10. But again, that varies with individual surgeons. Sometimes we may have to give a pulse before the surgery and then continue with other medications. But usually I prefer to make them stronger by using like plasma exchange a few days prior to the plasma to the thymectomy if they have some symptoms, and then continue after the thymectomy. Again, you don't want to do it
You
right
give the
before
plasma
the.
exchange to all the patients?
I'm sorry, what did you say?
You give plasma exchange to all the patients before
No, not
thymectomy?
all patients, only patients who have symptoms of even on their present medications. But most of the young patients, if they are if they're stable and do not need anything, I just send them directly to the to the thymectomy without any treatments before that. So so some patients may not need any it's only for people who have symptoms like I have difficulty swallowing, or if they have difficulty breathing, I might do plasma exchange and then stabilize them before they go into the plasma exchange. So we have done like a few treatments before, do the surgery, and then do a few treatments afterwards. So they just have the catheter in, they come in, stay in the hospital for a few days before, and then get their thymectomy and stay after the thymectomy for a few more days. That is only people who have symptoms, but who do not have symptoms, young patients, they are doing fine with the low dose of prednisone. I just send them for thymectomy as outpatient. So they go and see the surgeon. Mhm.
The next question is, in a clinically stable patient post thymectomy, when should we try to taper off pyridostigmine, steroids, and immunosuppressive agents, and in what order?
So that's a good question. So usually I like to taper down the prednisone first and try to get them to the lowest dose possible. And if they are on 10 and below 10, I might just leave it on that and then try to taper down if you look at the study of thymectomy, they took about 6 months to see the difference in the QMG, but people were still on the immunosuppressive therapy. So again, we don't know, do they go into remission in 3 years, do they go into remission in 7 years, we don't know that answer. So to the question about when do you taper them off of the immunosuppressive medications, we don't have a good idea of when. Actually, Dr. Michael Heher was trying to do a study looking at people who are stable on any immunosuppressive medication, irrespective of whether they had thymectomy or not. By tapering down, when should we taper down? When do they get worse? If you taper them down like after 1 year of being stable or after a few months of being stable, we don't have that answer. So how long do you keep them on the immunosuppressive? We don't have that answer. I had patients who've been stable on, didn't have any symptoms on CellCept for many years. And then I decided like, okay, that since they're stable, let me just get them off of that. But then they ended up having a relapse then. So it's hard to predict. And there's some people who have been stable after you take them off of that. So, I mean, I believe that you have to have a slow taper, even if you're going to take them off of the CellCept or Immuran. You need to have a slower taper, like over a few months, rather than just stopping them suddenly.
Are you ever able to completely stop all the immunogens when we call a disease, what we will define as a remission? And are we able
So,
to completely stop the after thymectomy ever?
I mean, we do have some patients who I have stopped completely of all the medications, except for, I mean, sometimes people may just need pyridostigmine as needed. And some people may have some chronic weakness, like mainly ocular. I mean, we see some people who are very stable, it looks like they're in remission, but they have minimal manifestations, like they have just a mild weakness of the eyes. When you test them, they don't have that symptoms, but when you test them, you see that. So they could be there's definitely certain percentage. I wouldn't say there's a huge number, but most of them end up being on some immunosuppressive medication. There are very few patients that we were trying to see what our numbers are, looking at just on pyridostigmine and not anything else, or not on pyridostigmine either, just being on in remission. There's very few. I would say it's a small percentage. It would be
My
less
last
than
question,
10%.
my last question will be after this, Dhananjay can take over. My last question is there any difference between the outcomes of transternal versus VATS versus robotic? Are there any studies comparing these surgical techniques? Do they make difference?
I don't think I've seen any study that compared these three techniques. I may be wrong, but I haven't seen any studies that compared these techniques. And again, so we had discussed this with our surgeon about when he uses which technique, or again, I think the robotic is used if it's a larger tumor. I mean, obviously or if the size of the thymus gland is large. Again, what is large? Again, I think they have certain criteria that they use to do the open thymectomy versus the robotic thymectomy. So, but majority of the patients, they have been doing recently are robotic thymectomy, because it's less invasive. So the recovery is faster for the patients, and the patients really like it. But I had a few patients who went in for robotic thymectomy, but with thymoma, and ended up having to have an open thymectomy afterwards, because they didn't see the margins very clear well on the tumor that they took out, because it's again robotic. There are some disadvantages of robotic thymectomy, that they may not be able to see see the whole tumor if it is a bigger or whole gland, if it's bigger, if it's infiltrated into the capsule, or you may have some trouble. They may have to open up again. All right.
Dhananjay, please, you may take over.
Yes, sir.
Uh, let's go beyond thymectomy. I think we have less time and there are too many questions. So let us have some of the medical
There are
questions
many
also.
questions.
Sure.
Yeah. So first two questions are from single sir. Do antibody levels don't correlate with severity of disease? Is there any explanation for that?
Um, that's a really good question, which I don't think any of us have an answer to that. I mean, there have been studies in the past that looked at antibodies and the correlation with the disease severity, and there hasn't been any correlation. Basically, right now, if a patient is positive, we say they are positive, and we don't care to even look for antibodies again. It's interesting that that has been brought up, because recently we've been seeing, like in studies, when we're trying to enroll seropositive patients, when they are requiring seropositive, they're testing them again and they are negative, although these patients have been seropositive previously. So now they're calling them as seronegative patients because they are. So it becomes a little difficult, but we don't know the answer why that. And we have seen people who have very mild elevation and have severe disease, whereas people who have like mild disease may have like very high elevation. So it's hard to, I mean, we haven't seen that correlation.
Then your views on thymectomy in patients more than
No thymectomy. We've got enough thymectomy.
okay, sir, fine. So there's interesting question. Any psychological impact of disease in patients? If patients are myasthenic, is there any psychological comorbidity in them? Are there any?
Well, yeah, so I think the psychological is not with the direct effect of myasthenia gravis, but definitely one would be the medications itself, and it depends on how severe the symptoms are. And this also affects young people who are, actually affects their daily activities, and they cannot do their routine activities, and so that might be cause some psychological effect, but it directly does not cause psychology. I mean, I have patients who have GAD antibody positive, like stiff person syndrome, where everyone seems to have some psychological effect. Whereas in myasthenia gravis, we don't see a direct psychological effect. We basically see only effects due to the medications or due to the activities of day being affected.
Then when to start immunosuppression in ocular myasthenia gravis?
Yes, I see that. So that's a good question. When to start immunosuppression in ocular MG. So that was the reason why they were doing this study by Michael Benatar, is trying to figure out, do we need to start this early to prevent the progression to generalization? Or, do we know that how many people, I mean, we know that if, like in 2 years, whether these patients will be generalized or not. But this we don't have that answer about when to start immunosuppression. But most of us, after that trial, Michael Benatar's trial, we do start immediately on both the prednisone and the pyridostigmine at the same time if they have double vision and drooping eyelids. Previously, we used to start just pyridostigmine and wait for to see if they have benefit with that, and then start the, if they have mild symptoms, I still do that. But usually if they have double vision, drooping eyelids, I might just go ahead and start on a low dose prednisone 10 milligrams and the pyridostigmine at the same time. And obviously if the patient is like someone like a driver, like a truck driver, you might have to be more aggressive in those patients earlier on.
The next question is, if the patient is in remission, but sometimes patients are unwilling to stop pyridostigmine, how to address that issue?
Well, pyridostigmine has very minimal side effects. I'm not too worried about like taking them off. If they feel comfortable being on it, I'm okay with just continuing on them on the pyridostigmine. The only side effects that we see is, diarrhea. If they're having that side effect, they automatically stop it on their own, but most of my patients, they feel comfortable just taking it, and I'm okay with just continuing that. And because it doesn't have any major side effects, long-term side effects on that.
Yeah.
And the
Next
reason
question
for
is, yeah,
reason for worsening, I see that reason for worsening on high dose steroids is, again, that's a good question, but this is doesn't always happen. It happens only when the patient is like having worsening of symptoms and you put them on high dose steroids. This is again, we don't know what the reason is. There's no explanation that we know of that why it happens. But we definitely see that if you suddenly increase someone who's on 10 milligrams and is having some difficulty swallowing and breathing, you might end up throwing them into crisis if you increase them to 60 milligrams suddenly as outpatient. So you can grow gradually. You can increase it to 10, 20 milligrams and gradually increase it up. But if you suddenly increase them to high doses, we don't know the answer to that.
There was something about safety factor of the neuromuscular transmission or something. I don't know. They used to talk about that earlier for steroid.
Yeah, the physiology is like the say. I mean, safety factor, again, that comes into play for repetitive nerve stimulation and the decrement. But I don't know if there is a direct correlation of the steroids. Maybe you're right, Dr. Kodari. I don't know the answer to that, but I don't think there's a good explanation that we know of.
yeah, if there is any
Right.
specific clinical feature in anti-agrin and anti-LRP positive myasthenia gravis.
Uh, No, the LRP4, again, Agrin hasn't been studied very well, but LRP4, the paper was it was just published actually, and that is not showing a significant difference from the acetylcholine receptor antibody. They still have like generalized myasthenia gravis, and they didn't have any specific phenotype that I know of that this group of patients had. Again, anti-agrin is not commercially available, so we don't check for that yet. Anti-LRP4 is commercially available, and we were part of the study with Georgia, and that's something which has been published, and we see that. But most of my patients with anti-LRP4, I have 4 patients with anti-LRP4 antibody. They are mostly mild in my case series. At least they are very stable patients in my. But the larger study has shown that they could be no different from generalized myasthenia gravis patients.
We have a lots of questions on drugs, what drugs to give. I want to know, what about tapering of immunosuppression? You got a person in remission. When and how do you taper off the immunosuppression? Do you ever stop it totally?
Yeah, definitely. I mean, I've tried. So this is what I was addressing earlier, Dr. Kotari. That's so what happens. Basically we there's no guidelines on when to stop. So Michael Heher was like Dr. Heher was trying to come up with a trial looking at when to stop this, and does stop tapering them off of would that worsen, or we don't have a trial to say when to stop. So I do have patients that I've tried, like I mentioned earlier, like I've tried to stop them. I mean, not stop them, but taper them off. And some of the studies have shown, like if you taper them gradually, like especially the CellCept, like if they're on it and have been stable for a few years, and you can just gradually, again, what is the number? I don't think we have a good sense of that. I mean, some of my elderly patients, they say, I'm stable. Why do I want to taper off now? I just want to be on it. I'm not having many side effects. And so I just continue on them. But if it's a young patient, like, in the 20s or 30s, and you're worried about long-term, having cancer risk, or, other side effects, then those are the patients I've been trying to get them off. And I've seen some of my younger patients I was able to get them off of all immunosuppressive, and maybe just keeping them on 10 milligram or less than 10 milligram of prednisone. I mean, the rheumatology literature shows that if they are less than 10 milligram or 10 milligram, that's okay. I mean, the long-term side effects are less compared to being on higher doses. So I'm okay with if they are on low dose prednisone, I just leave them on that, and try to get them off of all the other medications.
Many of
Is
us,
that
many of us here keep them on a small dose of azathioprine, maybe just 50 milligrams a day. And Dr. Khadilkar has also published a series, and even I have seen in my cases, if I try to go below that 50, then
Uh-huh.
after a year or two, they relapse. So one
Right.
tablet of 50 is what I think I am now comfortable with. And even Dr. Khadilkar has written a paper that once a myasthenic, something like that, is for life. So he
Did
is
you
not.
try to get off of that 50 also, Dr. Kodari, in those
I
patients?
tried 25. I tried 25 and they relapsed.
Oh, okay, okay.
there are some
Yeah,
questions on the steroid also? What are your experiences with high IV methylprednisolone? Can we try the other form of steroids have been tried, like
so yeah,
other than prednisolone?
the actor gel. Again, we haven't used that as much in myasthenia gravis, but as you know, the initial trials, the initial studies, or initially when corticosteroids, when the steroids were used, was actually adrenocorticotrophin was used many years ago. And but we don't use that as much, and I don't use pulse steroids much for myasthenia gravis. I just put them on oral steroids. Again, I think uh, I know some people do use pulse steroids, but I don't think there's enough data on that, on pulse steroids. The data is more on daily oral dosing, and it's easier to manage, I think, with the patients with this than the IV steroids.
Is it
I've
possible?
used it in the hospital, though. I have used them in the hospital.
Is it possible to bring this patient only on immunosuppression without steroids or without pyridostigmine at some stage?
Oh, I'm sorry. Can you repeat the question,
Is it
Dr. Kotari?
possible to bring these patients on purely immunosuppression, say azathioprine or something, without
Without
steroids and pyridostigmine?
Yeah, definitely. I mean, so pyridostigmine, not everyone has benefit with pyridostigmine, especially the mask patients. Some of them may actually have worsening of symptoms on that. And so I haven't, there's some patients who are not on that. And even prednisone, I've taken some patients completely off of prednisone because of the side effects, and just maintained, or they have, since when they have benefit, as I'm tapering down, like I mentioned, I'd like to taper off the prednisone first because of the immediate side effects of that, and then just left them on Imuran and other medications. So I've used that.
Mamatha, don't we try to aim for remission? And by remission, I mean somebody who doesn't need pyridostigmine any longer. So
Yeah.
if somebody still needs pyridostigmine, then probably I feel that his immunosuppression needs to be higher. And so somebody, do we aim for that, or we don't aim for getting the person off pyridostigmine?
Um, Actually, I mean, I don't aim for taking them off of pyridostigmine. I know we do aim for again lowering the MG-ADL, or I mean, I know we've been using the MG classification and the intervention status, post-intervention status more in the past trials, but now we are using more. I mean, every patient who comes in, we do the MG-ADL and we see if they're improving or if they're stable. That's what I use mostly now to get them off of these medications. So some of the patients are on pyridostigmine, but they still, again, do they need it? I mean, I do look for fluctuations. You're right. I mean, if they have those fluctuations, I mean, they probably cannot be tapered off. I mean, so I asked that question, but if they are stable on just that, not having those fluctuations. I know some people still are taking the pyridostigmines, although they do not have those fluctuations, So those are the patients that might continue, like try tapering off, even if they're on pyridostigmine.
There was one question: is there any protocol for pyridostigmine for the intubated patient?
So that's a good question. Actually, pyridostigmine, we try to hold in person when people come in acute crisis. The reason is because, when they intubated, again, you're worried about the secretions. So we usually tend to hold that. I mean, there's no definite, answer that you have to hold it, but I prefer it because of the secretions, to avoid the secretions, because again, as we know, pyridostigmine causes increased secretions. So I
And
just hold it until.
this is even if the patient has come crisis because of clear cut because of the drug default.
Which drug are we talking about?
Pyridostigmine, suppose patient has not taken for 1 week and then he has landed up in crisis. Even
Well,
then,
no, I mean, in that case, we probably would give the pyridostigmine and try. But if he needs intubation, I think
okay.
uh, beyond that, probably just the pyridostigmine. So I usually, when they come in crisis, they have been, either they need plasma exchange or IVIG. So we intubate them and, give them is to hold the pyridostigmine briefly until the secretions are. But if they're not having too many secretions, I'm fine with continuing the pyridostigmine. And
Yeah.
so I see.
Management of myasthenia gravis diagnosed for the first time in pregnancy. What are the drugs we can use and what are the drugs we cannot use, basically?
So MG diagnosed first time in the pregnancy, as we know. Again, everything has to go through the OB, make sure that they are okay with whatever we put in. But prednisone probably is the best medication during pregnancy rather than any other medications. I would be a little hesitant to put them on any immunosuppressive therapies in the first 2 trimesters, and then after that, it's fine to use. But again, plasma exchange might be a problem because of, again, you're filtering out the hormones and along with the other proteins. So you worry about that. But I would prefer, I mean, usually prednisone is preferable. Once they deliver the baby, then, I mean, if they're in crisis or something, I mean, it's okay to use the plasma exchange at that point, but we would avoid those. And the risk of IVIG would be increase in, clotting again. So especially with pregnancy, having an increased risk of clotting, IVIG may not be the best medication to use during pregnancy. So you have to avoid, if we can, during pregnancy. I had to use one CIDP patient. I still had to give them IVIG, but I prefer not to give IVIG during pregnancy.
If a
And
patient who is receiving azathioprine or some other immunosuppression becomes pregnant, then what to do? We should withdraw them.
I mean, I think that's a good question. Like, do we stop it? It's just like seizure patient, do we stop it or do we continue and make the MG worse, So that is definitely, I mean, something we need to discuss with the patient. I mean, I would like to stop them in the first 2 trimesters if we can and just put them on steroid alone. But that discussion, I think we should have with the patient even
Yeah,
before they.
and the patient has already got exposed. If you're saying
Yeah.
it means the fetus is already exposed.
That's right. I mean, if it's already been in the first trimester, I don't know if it would make any difference. But I think if it's a young patient, it's better to start the discussion earlier on and let them know earlier on that pregnancy. I mean, this is the effects on pregnancy. Can be, I mean, and usually Immuran, we try to avoid it in young patients because of that reason. Again, we worry about the IVIG probably would be better in younger patients because you can just stop it. And less side effects, at least initially, and when they get pregnant you can just hold it. So I prefer in younger patients to just do the IVIG maintenance for some time.
We can stop them if the patient comes
I-
at preconception level.
I'm sorry.
We can stop them if the patient comes at preconception level. If patient discusses
Yeah,
before becoming pregnant, we can stop them.
that's right. And then maybe put on the lotus prednisone, and if we can.
Mamta, I had a question. In India, we get generic forms of rituximab, and so it is quite cheap as compared to the other
Is that
IVIG or everything else. And I have a feeling after seeing some of the patients who were difficult and who required repeated crisis, and once they have been started on rituximab, they are off everything and they just come for one injection once in 6 months.
6 months?
I
Yeah.
have a feeling, are we using rituximab less as compared to what we could? I
Yeah.
mean, we wait only for somebody who goes into crisis. Maybe.
Yeah. So you're right, Dr. Godar. I mean, I think it's a really good thing that you brought up. Actually, we like rituximab. The only thing is this trial did not was negative. That's why we don't use it. But the other main reason is insurance gives us a lot of trouble in US to get rituximab. We can get an approval for MG. We have to go through a lot of hoops to get that. I mean, we have to put in a lot of evidence, and so only musk myasthenia gravis we do have. We have great, I mean, patients do get that quite easily, but other than musk myasthenia gravis, it has been very difficult to get the approval. So I think you're right. I mean, it's also depends on the availability of the medication and depends on what medication you know are available and how much they cost. Rituximab is very expensive, so in US, so it becomes very difficult for patients to take that. And again, I think so do you see many patients with again infections in these patients or PML in those patients? You have many, okay, and you don't test for that. And I agree with that because even in this trial they haven't seen any patients with PML. I think it's in the MS literature they've seen PML, but in our MG literature, we haven't seen PML. Even in other neuromuscular conditions, I use it a lot in CIDP also, CIDP patients, and I haven't seen problems with that.
See much more problem with azathioprine. We see tuberculosis with azathioprine. We see all sorts of things with, but somehow, at least I don't know if other people have seen. We've not seen too much infection or other problems with rituximab. Comparative.
Yeah, interesting. That's interesting. But patients definitely like it because it's once every 6 months instead of taking a medication every day. So I think one of the questions they asked here was why was musk positive patients worsen of pyridostigmine? I don't think we have an answer on that, why it would be worsening, but that's only a small percentage of patients with musk myasthenia that have shown to worsen on pyridostigmine, not all of them. So again, even with generalized myasthenia gravis, there's some patients who do not respond to pyridostigmine and may respond to other medications. So
Uh,
again, that's
uh,
something.
I
Others have asked why steroid
we have
versus
to
myasthenia gravis.
make this the last question. It's very late for her. For us, it's it's the
Now,
daytime. We have to let her go.
others have asked why steroids. Many of us have asked why the steroids worsen the myasthenia gravis.
She already
Yeah.
answered.
Yeah, I don't think we have the answer specifically for that. But like I mentioned earlier, I think Dr. Kothari was talking about the safety factor, but that's in the physiology. Like there is a safety factor that is the increased acetylcholine that is released in the quanta. When it's released, there's an increased amount that is released. So when this safety factor is decreased, I think that's what you were pointing to. But I don't know if there is a specific answer to that, actually, why the steroids worsen myasthenia gravis. And this happens only when they are in acute exacerbation, when you suddenly increase that. So if you increase only mild, if you increase by 10 milligrams or 5 milligrams, we don't see that kind of effect.
Uh,
It's only when you increase from 10 to like very high doses.
What about priming? We have seen that if you give IVIG and then on day 3 or day 4 you give a full dose steroid, nothing happens then. So if you get the person out with IVIG or plasmapheresis.
Yeah, you're right. I mean, that's basically what we were saying. Like, we usually admit the patient, when they come in crisis or exacerbation, we usually admit the patient and do the plasma exchange or IVIG. And then by, like you mentioned, either the third day or even the fifth day or before they leave the hospital, we go up to very high doses. So that's by then, one of the
Okay.
reasons is they're already intubated also, like, or they are in the hospital. Even if they worsen, we at least have an environment where we can take care of that. And then we decide on, like, we go up to high doses and then taper it down gradually. So in acute crisis you do need them to be on high doses, but it's when do you start it is the question. We can't just tell the patient on the phone, like, go up on this to 30 or 40 milligrams. We don't want to do that. We just, if they call in and say that I'm having this worsening symptoms, I might just increase small amount and see. But if they're having some crisis, I just say come into the hospital.
Okay, Mamta, thank you. I think it was a
Thank
very
you.
nice session. Thank you for accepting our invitation for the talk. And we
Sure.
look forward to calling you again at a later time. Thank you.
Thank you for the opportunity.
Thank you,
I
Dr.
really
Vaibhav. Thank you, Danny.
Thank you.
Thank you, sir. Thank you, sir.
Thank you,
appreciate
madam.
Take
all.
care. Take care. Bye.
Thank you.
Thank you.